Be here with you for our monthly clinical conversations session. I'm Barry Servette, and I'm the medical director for MCPAP. And as you may know, we have these clinical conversation sessions every fourth Tuesday, most months. And today, our topic is really, as you see, it's an update on depression. And actually, we are really pleased to have our very own Dr. Bruce Waslick, who is the West Central MCPAP team medical director for us. And so I'm going to introduce him further, but before we start, just a couple of housekeeping issues. First of all, we record the sessions and they are available on the MCPAP website at www.mcpap.com. And you'll be able to get a copy of the slides as well on the MCPAP website at the Toolkits and Resources page, which is under PowerPoint presentations on the website. And actually, you know, the topic today is related to our set of clinical algorithms, and those algorithms are also available on the website, as well as our clinical pearls documents, which are paired with each of the algorithms. So Dr. Waslick is very graciously willing to take questions throughout the presentation, and he's also going to leave time at the end. So if you have a question or a comment, you can use the chat. You can type a question into the question box. And so if you prefer to read it yourself or ask it yourself, you can just ask to be unmuted. You can say what your question is just generally, and then you can just ask to be unmuted and we'll unmute you. Otherwise, I'll just read your question to Bruce. Finally, at the end, excuse me, you will receive a survey, and we really appreciate if you would take a couple minutes it's very quick. It's a quick and easy survey, and we really would like to have feedback so that we can improve future presentations. You can give us ideas about topics you want to hear about, or just any feedbacks about how this is working for you. So just before we start, I want to say a few more words about Bruce. I am biased because Bruce is my friend and colleague, and he's been at Baystate with us for many years. He's the chief of child psychiatry at Baystate. He's an associate professor of psychiatry at UMass Medical School. He's, obviously a board certified general and child psychiatry doctor, and he is a member of ACAP and APA and AMA. He's actually the medical director for outpatient psychiatry services in our child psychiatry division. And as I mentioned, he's the medical director for the UMass Baystate team for MCPAP. He did his undergraduate degree at UMass Amherst. So he's also a native of Western Massachusetts. And he went to med school at Tufts, and he did his clinical training in child psychiatry and general psychiatry at Tufts New England Medical Center. He completed a research fellowship in child psychiatry at Columbia, and he was on faculty for 10 years at Columbia and NISP, New York State Psychiatric Institute, before coming to Baystate in 2005. I should mention also that Dr. Waslick is one of the people who have been kind of contributing to our knowledge base in how to treat adolescent depression as a leader of the Columbia site for several multi-center trials, notably the TAD study, which is a landmark study in the treatment of adolescent depression. And he was also involved in leading the Columbia site for the CAMS study, which is also a landmark study in anxiety disorder treatment for children. So we're very fortunate to have Dr. Waslick here, and just to kind of reiterate, this is really part of our effort, MCPAP, to have detailed and practical clinical guidelines and algorithms for the treatment of common psychiatric disorders in the primary care setting. And so we did give, and Bruce gave a very nice presentation about the depression algorithm a couple of years ago, and so we are starting to provide updates because we want to keep these algorithms fresh, and we want to remind you of them. And so Bruce is going to give an updated sort of overview and presentation about how we, have all agreed would like patients with adolescent depression to be treated in the primary care setting. And so with that, I'm just going to hand it over to Bruce, and he will take it from here.
Okay, thank you, Barry. That's a wonderful introduction, and I am very pleased to be here. It was about 3 years ago that we first did our depression algorithm presentation, and I hope people, coming to this presentation today, I hope you've had a chance to experience it and use it, and you'd be interested in any comments maybe at the end about how helpful you feel like it's been. Also aware that there may be people who've never been introduced to the algorithms before, and this is your first introduction and the first time through the depression algorithm. So, I'm going to go through a set of slides with some orientation to the algorithm process, and specifically get into the depression algorithm. And again, feel free, I think for this, if you have questions or comments, put them in the chat. Barry will interrupt me, and we'll take them as they come. And hopefully we'll have some time at the end to deal with any particular ones. So moving forward. So we're going to do an introduction to the MCPAP clinical algorithms in general. We'll do a presentation of the MCPAP depression clinical algorithm, and then hopefully we'll have some time for questions, comments, discussion, feedback. So the idea behind the MCPAP clinical algorithms for people who are new to it is really, the idea was to create practical clinical guidelines for primary care providers when dealing with the common mental health problems. So we've rolled out guidelines and algorithms for depression, anxiety, ADHD, OCD, so those are the common ones that you would see in primary care practice. And the guidelines are not meant for specialty care. They're really meant for primary care providers. The guidelines encompass some screening procedure recommendations that you can use in your office. We do usually follow, in all the algorithms, the idea of doing some screening and then getting a little bit more in depth around doing evaluations, figuring out how to do a good mental health evaluation as a primary care provider. And once you've gotten through the evaluation process, and the evaluation should inform your treatment planning considerations. So establishing a diagnosis in this algorithm, establishing a diagnosis of depression or clinically significant depression should inform what you're going to recommend for treatment for the families. And because we're not sort of thinking that primary care providers are going to be doing some of the psychosocial treatment, like formal psychotherapy or family therapy or things like that, we've included medication treatment guidelines. So primary care doctors, we know, are getting called upon more to be involved with medication treatment of mental health problems. And the medication treatment guidelines are meant to give you a little bit of information and some practical tools about how to go about thinking about medications for kids, in this case with depression. So the content is developed with you guys in mind. Content is developed to be most helpful for the primary care provider and regular primary care practice. The content also includes procedures that can be performed in all algorithms in the context of regular primary care. So those would be like screening procedures or evaluation procedures. The content recommends the use of standard, well-validated clinical rating scales that can be used in primary care practice. So when we recommend a tool, it's after we've done some background research on it and feel like there's enough evidence to support its usefulness in practice, but also in primary care practice. And the content will generally recommend the use of medication guidelines suggesting evidence-supported first-line medication treatments for mental health conditions commonly treated in primary care. And, you know, obviously, we would think depression would be one of those. Anxiety would be another. ADHD would be a third. And so those are the first three algorithms that we rolled out. But it's really meant to help you practice, you know, help you screen, evaluate, and practice. And when you're treating depression, sometimes you're practicing within a team environment. So, so how did we develop the clinical algorithms? So the content was really developed through a clinical consensus process. So we have a MCPAP medical directors leadership team that meets on a monthly basis that identifies conditions that we think would be great to develop clinical practice guidelines for, and to kind of get some ideas and conceptualizations about what the guidelines should look like, what they should include. Our initial guidelines were for the different conditions that we've developed so far. The starting place was some clinical guidelines developed by Heather Walter, who's on the MCPAP Medical Directors Leadership Team, and her colleagues at Boston Children's Hospital initially for the PPOC practices, the ACO centralized through Boston Children's Hospital. But then we worked through them for guidelines that we thought would be available for all practices in Massachusetts. And like I said, the first three clinical algorithms were probably three conditions that you're seeing regularly in your primary care practice: depression, anxiety, and ADHD. So the applications of the clinical algorithms, there's a number of different applications, and we're hoping that the guidelines are going to be useful in a number of different ways. So really, we're trying to help train primary care providers in basic evidence-supported tools and procedures for the mild to moderate, relatively uncomplicated forms of mental health problems that can reasonably be handled in primary care practice. So we're not trying to make everybody, you know, all the primary care practitioners into specialty child psychiatrists, you know, but, you know, we understand that there probably are not enough child psychiatric practitioners in Massachusetts to take care of all the mental health needs of children. So we are recruiting primary care providers into the workforce to say, you know, we consider mental health to be an important component of healthcare. It's an important component of kids' healthcare. So having primary care providers involved with that, supported with evidence-based tools and guidelines and MCPAP consultations, we're hoping that primary care practitioners will become part of the workforce for dealing with mental health issues. It's also to help MCPAP consulting teams, our teams at the different sites, provide consistent training and guidance to primary care providers during our phone consultations and face-to-face consultations across the state. If people are new to MCPAP, I hope you really connect with your local MCPAP team. I think they're going to be very helpful, or we're going to be very helpful for people, you know, practicing in Massachusetts, practicing primary care for children and adolescents. And the applications are meant to kind of help us be more consistent as consultants. The algorithms likely will not be the best starting point for severely ill, treatment-resistant, or highly complicated presentations of mental illness in primary care. We know we're not expecting primary care providers to, you know, be the first person in to try to help those particular patients. Those patients are likely better served by getting them more referred to specialty care. And sometimes it might take a phone consultation with a MCPAP psychiatrist to identify the kids that you can treat in primary care or try to treat in primary care versus kids who really should be referred to more specialized care. But the algorithms themselves are really meant to help you work with the mild to moderate, less complicated, less treatment resistant cases in your practice. And again, the algorithms are meant to be embedded in the entire MCPAP program. So primary care providers are encouraged to make liberal use of MCPAP phone consultation and face-to-face consultations for complicated treatment-resistant or severely ill presentations rather than relying on the MCPAP clinical algorithms. And in general, we're going to recommend you hopefully develop a good working relationship with your local MCPAP team and providers. Get to know them on a first name basis so that we can help support you guys doing the work in your practices. So we're going to go now into the depression clinical algorithm. And it's really it was the first clinical algorithm that we rolled out by the MCPAP teams. And consistent with the other guidelines, we're trying to provide clinical guidance for the primary care provider in terms of screening for depressive illness in children and teens, diagnostic evaluation procedures. We're not trying, again, to turn you into psychiatrists doing diagnostic evaluations, but diagnostic evaluation at the primary care practice level is important. And we're going to talk about that, why it's important. And one of the reasons it's important is that your diagnostic evaluation should really inform your treatment plan considerations. So doing a good diagnostic evaluation should help with some of the treatment plan considerations. And you're going to see that later in the algorithm. And then also thinking ahead that probably a lot of primary care doctors are prescribing antidepressants for depression in kids and teenagers now. And giving you some guidance about what we would recommend for initial medication selection and management procedures. Here's what the algorithm looks like, and it's probably small to your screen, and I'm going to go through it in detail, but this is just a general overview for what it looks like. So at the top, you're going to see sort of screening procedures. In the middle, we're going to talk about evaluation. And as we get down lower through the algorithm, we're going to be talking more specifically about initial treatment and then follow-up care. So we're going to go through this in all detail. I just wanted to give you an overview of the MCPAP depression guideline and what it looks like. I do again want to acknowledge that at the bottom here that the origins of the process and the development was supported a lot by Heather Walter and her colleagues at the Department of Child Psychiatry at Boston Children's Hospital and their work with their primary care practices. So again, this is what I said before. The top is screening and evaluation procedures. We're going to look at that in more detail. Clinical decision-making procedures are in the middle. Initial medication selection support is the third big chunk, and then the fourth big chunk is some guidelines on how to do follow-up and monitoring support. And we'll go through each of these in more detail as we move through the guideline. I should mention also that the guidelines themselves and the clinical algorithms do also come with a set of what we call clinical pearls. Clinical pearls are what we would recommend from a psychiatric perspective about some additional details and thinking about all these parts, screening, evaluation, and treatment decision-making. And they're too detailed to kind of enter into the clinical algorithm itself. But as you go through the guidelines and you make use of them, I invite folks to really look at the clinical pearls that are attached to the guidelines, because I think they go into a bit more depth on some of the different questions that arise and to provide some additional guidelines for primary care providers. Again, this is my third thank you to Heather, and she's been a big part of this process. So here's the screening and evaluation procedure. So the idea would be that, let's say at a well-child visit, you're going to screen. I mean, most people in Massachusetts at this point, most primary care providers are screening for behavioral health concerns or mental health concerns. And, there are different sort of screenings. So some might be using the PHQ, which is a screener for kids 12 and up, looking at different types of mental health issues, the patient health questionnaire. Others are using the pediatric symptom checklist. Whatever screener you use, it's meant to kind of set a flag. You know, if kids are doing fine from a mental health perspective, then their screens are going to be negative. But if they, at a well child visit, they screen positive, then, you know, a screen is a screen. A screen is not diagnosis, but it should trigger a set of procedures leading to evaluation that we're recommending. So once you have the screener done, then and the screen comes up positive for mental health concerns, we'll talk a little bit more detail what the screeners are useful for and what they actually look like and how to know where we may be dealing with depression. But if the screen is positive, then we want folks to do a brief interview focusing on distress, impairment, and danger. If in general guidelines, if after the screening is positive, you're convinced that we're dealing with sort of either subclinical depression, you know, or you know, symptoms that might be related to an acute stressor and not really a depressive illness, then we might want you to do some, recommend some self-management and some follow-up and make sure that things don't progress. If there is a concern for clinical depression, then we would recommend conducting a focused assessment, including evaluation of things like precipitating factors, get some symptom rating scales, which we're going to talk about in a few minutes. Take a look for, is there a family history of mood disorders and other types of red flag issues for medication use. One of the red flag issues, obviously, is any concerns about imminent danger and suicidality. So we'll have to do an assessment about suicidality. And if there does not appear to be imminent risk for danger, then, you know, we can proceed through the algorithm. If there is a concern for imminent danger, then at that point, the screen should turn into a referral to a crisis evaluation for emergency psychiatric assessment. So when the screen is positive, do a brief interview and figure out, you know, make sure the kid is safe to continue with the rest of the algorithm. And if there's any concerns about safety, make sure you refer the kids for an emergency psychiatric assessment. And if you need any help determining where things should go in terms of a particular kid or assessment, you can feel free to call the McPap child and adolescent psychiatrist for any kind of guidance or help in terms of sorting out things at this level. So that's the screening and some of the evaluations. So the screening, here's the pediatric symptom checklist. You can see the 17 items that, at least in Western Massachusetts, a lot of folks are using the PSC 17 to screen for both internalizing symptoms, ADHD symptoms, externalizing symptoms, and then total problems. You know, and this just gives an easy way to sort of calculate the concerns. In terms of our algorithm, where we're particularly concerned with depression, then we're going to be looking at the PSC 17 internalizing subscale. And what we've suggested as a screen, as a positive screen, being greater than or equal to 5. So you can take a look at some of the items that are going to load onto a depressive illness. Number 2 obviously feels sad and unhappy. Number 6 feels hopeless. Number 9 is down on him or herself. Number 11 gets out the concept of anhedonia, which seems to be having less fun. So those are some of the screening items. And if you're scoring 5 or greater on the internalizing subscale, then that's a positive screen. And then we're going to suggest further evaluation. Further evaluation is going to be a combination of an interview, but we also recommend using, again, the rating scales. For adolescents, this is the PHQ-9 that we've recommended as a very good evaluation tool. It gives you kind of a combination of whether the kids currently are going to be meeting criteria for clinically significant depression, but also serve as a guideline for how severe the depression is. So up here on the left-hand side of the screen, you can see total scores on the PHQ-9 or the PHQ-A, 1 to 4 minimal depression, 5 to 9 mild depression, 10 to 14 moderate depression, and then the more moderately severe depression is anything 15 or higher. 15 or higher, you know, you may try to treat in primary care, but we're really looking at sort of scores between 5 and 19 or so to say these are the mild to moderate kids that we'd be wanting to treat in the medical care, in primary care. And then once you've done an assessment instrument like this, you should go take the extra time to just make sure that the kid has filled out the screener, the evaluation tool in a valid way, and make sure that if you can, go through different sort of things that look like depression, but may be different than depression. So normal bereavement, if somebody's gone through a recent loss, a death or a severe loss, normal bereavement can sometimes be confused with major depression. Bipolar disorder, and that's important to kind of get a handle on. If kids have shown symptoms of mania or manic episodes or hypomanic episodes, the opposite of depression, sometimes they will certainly present with depressive symptoms, but the treatment for bipolar spectrum disorders is very different than treatment for what we call unipolar major depression. So screening for whether kids have ever had manic episodes or hypomanic episodes is pretty important. Looking for medical disorders that sometimes can show up as depression-like symptoms or even depression, things like endocrine disorders, hypothyroidism, infections, things like that. Make sure it's part of the evaluation. Make sure that we're not dealing with a primary medical problem that is, you know, leading to depressive symptoms, because the treatment for that would probably be to try to correct the underlying medical problem first rather than treat for depression. Occasionally there are negative reactions to medications that can present with depressive symptoms, illicit substance use, substance abuse, you know, so digging in fairly deeply here and trying to get a good assessment and a formulation about what's going on is part of the overall evaluation for kids. So it's partly based on clinical interview with the kid, partly based on clinical interview with the parent or the guardian, and also using some rating scales to help to get your best diagnostic assessment and formulation about what's going on. And again, I'll say this as a given, but if you're ever unclear, you know, we've certainly done phone consultations and face-to-face consultations with the following question. I've just evaluated a teenager and she's got clear-cut depression, but she's also got either a family history of bipolar disorder or some episodes in the past which sound like they were manic episodes or hypomanic episodes. Would you evaluate this kid to make sure we have the diagnosis right? And I think that's a perfectly good, legitimate use of MCPAP, both in terms of phone consultation and face-to-face consultation. Because if there's any question about whether there's a bipolar diagnosis or a bipolar diathesis, sometimes it takes, you know, more specialized assessments to really give you a good feel on that. So if at any point during the evaluation you're not quite clear of what the right diagnosis, what the formulation is, feel free to make use of MCPAP consultation services.
Hey, Bruce, could you just take a moment to define what you mean by the term diathesis?
Let's see, how did I use it? Did I say?
You said a
bipolar diathesis.
A bipolar diathesis, yeah, yeah.
Yeah, so when I use diathesis, it means that they're at risk for bipolar disorder. And risk could be done in different ways. One is that they have symptoms of bipolar disorder, but have not been characterized completely as bipolar disorder. The other diathesis might be that they have a very strong family history of bipolar disorder. And again, a strong family history of bipolar disorder does not mean that somebody has bipolar disorder when they come to see you with depression, but it might inform you about looking a little bit more deeply whether the kids have actually had episodes of mania or hypomania, particularly, that may have gone either unrecognized or not thought to be as much of a concern in the past. you know, I'm kind of a classicist when it comes to making the diagnosis of bipolar disorder, is that, you know, I want to be convinced that kids have had episodes of hypomania or mania. But, you know, sometimes that's hard to figure out. It's hard to figure out sometimes with a specialty evaluation. And so if you have somebody with a very strong history of bipolar disorder with some symptoms that, you know, that would speak to mania, you know, mood swings that last days or weeks where, you know, it's the opposite of depression. They're feeling very high or very talkative or animated. And usually in that situation, looking very different than their kind of baseline presentation. Like somebody said, wow, that person is really acting differently or behaving differently, you know, over the last, you know, 4 or 5, 6 days consistently. Now, I also hear a lot about kids who have what I call emotional reactivity. You know, if something good happens, they're really happy. If something bad happens, they're really sad, or they're really angry or irritable, and they have a lot of shifting mood swings. And whether that is a forerunner of a severe mood disorder like bipolar disorder or not, I think the questions, I think that's still not quite clear. So it's when I'm talking about looking at a diathesis for bipolar disorder, I'm thinking more about clear-cut episodes of mania or hypomania. The mood swings, the highs to lows, the emotional reactivity, that may be an indicator of some problems, but that was not what I would call, you know, more classic bipolar diathesis or bipolar diagnosis. Hopefully that answers the question. But a very good question. And again, when you're in doubt, make sure you feel free to contact McPap for help sorting these things out. So we have 2 different rating scales that we are recommending for use. One of them, the Mood and Feelings Questionnaire, it goes down to the ages of 8 in an evidence-supported way. So for the younger kids, 8 years old, Mood and Feelings Questionnaire, and the upper age for that is 18. The PHQ-9 or the PHQ-A, more recommended for ages 12 plus. The cut point of 10 being moderate and severe 20. And when kids are starting to get depression scores at the level of 20, you know, that might be time to think about whether they need specialty care as opposed to primary care. And again, red flags, diagnostic rule outs, suicidality, psychosis, severe histories of trauma, significant substance abuse, all red flags, might require additional psychiatric consultation before you move into treating those kids. And then the diagnostic rule outs, which we covered in the previous slide.
Hey Bruce, so we have a question from Judy Tapper,
Sure.
which, you know, may be relevant to this part of the talk. She brings up, you know, the comorbidity of marijuana use
Yes.
with depression, and she was wondering, she noted, you know, very aptly that many of these patients, you know, who are depressed and smoking marijuana on a daily basis don't really respond as well to standard treatments for depression alone, you know, and she wondered whether or not these patients should be treated more by specialists rather than primary care providers. And so I wonder if you want to speak to this. My thoughts about this, just from the standpoint of McPap, is that you know, any patient that's not doing well, I think, you know, we encourage you to call the hotline and to have a telephone consultation. Some of these patients we may want to do a face-to-face evaluation on if we're not sure, you know, what to recommend. There's always the option to refer the patient to specialty care if patients aren't doing well in the primary care setting. I guess I hesitate to say that as a rule, just because so many of the adolescents, you know, that we see with depression are using marijuana frequently, and you know, whether they're self-medicating or if the marijuana itself is really contributing to the depression, you know, for a variety of reasons. And so I hesitate to say that all these patients should be referred to specialists, but I think at the very least, you know, there needs to be a very clear treatment plan for addressing the marijuana or the cannabis use disorder, that's complicating the treatment of depression. So what are your thoughts about that, Bruce?
No, I agree with you. I mean, even if you refer for a MCPAP consultation, I think getting specialist consultation on again, that's one of those comorbid conditions that I agree with you, Judy, that can really interfere with treatment. And sometimes kids don't even know about it because they're using the marijuana to help them deal with the depression, and that's their own sort of chosen avenue. And sometimes, it's the marijuana use that's making kids look more depressed. So it gets very complicated. So I would agree, we don't want to have all those kids necessarily quickly referred to specialty care, but I also think that primary care docs trying to treat kids with that comorbidity might need some support and some help. And I think for kids with marijuana use, you could probably use the depression algorithm relatively well. For kids with marijuana abuse, it might have to be modified in some way. So, so it's a really good question, and it's one of those things I think would make great, at least MCPAP phone consultations, if not face-to-face consultations.
Thank you, Bruce. And I'll also just add, John Strauss mentioned in the chat that we should remind everybody about the ASAP sort of specialty consultation arm of MCPAP, and so that's kind of an additional resource that we have within MCPAP to get some specialized consultation for primary care providers around sort of how to put together a treatment plan and how to initiate treatment for kids, particularly teenagers with substance use disorders. And so that's kind of available through all of the regular MCPAP hotlines, and we can kind of help to navigate those resources. And it's provided through Boston Children's Hospital.
Yeah.
Barry, it's John. Just a reminder also that we have the new addition on that actually provides virtual counseling around substance use. We have a counselor that's available to telehealth counseling for any of your patients, and that's available through the ASAP program.
Yeah, thank you. I mean, one of the things, I was in a meeting and I heard that there may be hints that the ASAP program is a bit underutilized, which would surprise me. I would think that would be one of the most highly utilized services in the state. So,
in
great
general,
to remind folks.
All adolescent substance use disorder resources are underutilized. It's very interesting. We know that almost every adult, with a substance use disorder started their journey in sort of their addiction and use disorder in their teenage years. But it's very, many of the kids, that we see, don't get referred, to treatment. And then the ones who are referred, many of the families are not sort of following through with the referral. So it's a very challenging problem. And I really encourage people to take advantage of this ASAP consultation arm because, we have people who are really expert at helping to kind of address, some of the barriers to accessing resources, both on the patient side and the system side as well.
All right, so this is the Mooting Feelings questionnaire. You can get this online. It's public domain, so it's not proprietary. You don't have to pay for it. And this looks similar. So we've gone through screening and we've gone through evaluation, diagnostic evaluation, and then, again, the idea behind the evaluation is to help inform your treatment. And this is just a graphic to kind of remind folks different broad categories of kids, and when we're dealing with individuals, sometimes it's hard to put them in broad categories. But for useful algorithm decision making, subclinical to mild depression, you might choose things like guided self-management with follow-up, giving them, reminding them about, healthy living and coping with stress and getting good sleep and exercise and things like that. Things that they can do on their own to improve their own sort of mental state with follow-up. So, you're not severely depressed, but we've got some things going on here. I want to make sure that, you know, you take care of yourself, you deal with the things you need to deal with, and I'd really like to see you again in 2 months just to check in to see how things are going, you know? So that's more guided self-management with follow-up. Um, you know, so you keep the kids under observation, but not in active treatment. The mild to moderate depressions, or if the self-management is unsuccessful, then we need to think about treatment. Therapy, medication goes on the table for discussion. And then again, the severe depression, at least a referral for specialty evaluation, but most likely referral for specialty care for therapy and medication management until stable. And, you know, once kids are stable and they're doing well, I mean, I think, you know, one of the things that we've taken to out in Western Mass is working with primary care doctors is if they need specialty care for a while, but they do well, and maybe they could be referred back to specialty care, every kid we can transfer out of specialty care into primary care, if they're doing well and they're stable, allows us to take another kid into specialty care. So that's a model of care we've been using. And it's sort of like, you know, come over to specialty care for a while, get effective treatment, feel better, get stable, go back to primary care, maybe for ongoing medication management, and then we can take a new kid in for an evaluation for specialized care. Medication support. So again, we're not going to talk about psychotherapy. Mainly, you should, I mean, if people want to know about psychotherapy, it's good to know and have some idea about what psychotherapy is and how it works for kids. And it's an evidence-supported treatment. There's no doubt about it. So I'm not trying to give short shrift to psychotherapy, but most primary care doctors are not going to be involved directly with psychotherapy, more indirectly, and they may be involved directly with medication selection and medication treatment. So in general, we have still, this is not different from what it was 3 years ago, we have 2 FDA-approved medications for depression in kids and adolescents. Fluoxetine is approved for depression for kids 8 and above. Escitalopram or Lexapro is approved by the FDA for kids 12 and above. There is some decent support for other medications like sertraline, but it remains not FDA approved. And so we've taken to generally preferring FDA approval as part of the medication recommendations, at least in depression. The idea behind, you know, we usually go with the algorithm, start low, and increase the dose slowly and carefully, especially with kids. Fluoxetine, we're recommending 5 milligrams starting dose for under the age of 12, 10 milligrams if their age is 12 and above. Escitalopram, 5 milligrams for 12 and older. And then sertraline, 12.5 milligrams if the age is less than 12, and 25 milligrams if they're 12 or older. And if they can tolerate the initial kind of test dose for 1 to 2 weeks, then try to get to what we usually think of as the therapeutic dose. So for under the age of 12, try to get to 10 milligrams for 12 and above, try to get to 20 milligrams for fluoxetine. Escitalopram, try to get to the usual therapeutic dose of 10 milligrams for Lexapro. And for sertraline, you know, try to escalate the dose to the 25, 50, 75 dose range, again, as tolerated. You know, so, you know, start low and go slow is probably a good way to think about medication selection support. And over on the right here, we have, you know, we want to monitor on a weekly basis for agitation, suicidality, severe side effects. You know, all of these medications for kids, the antidepressants continue to have a black box warning regarding the treatment emergent suicidality. And I don't see it frequently, you know, and I see lots of different potential side effects. But, you know, it happens. It's not a high frequency, it's a low frequency, but it is potentially very serious. So if you hear about severe agitation or new onset suicidal ideation or planning, you may have to refer the kid to a hospital or crisis team. If their safety can be ensured, you may have to relook at the medication. And I do handle a lot of phone calls about this, you know, I just started fluoxetine. A week later, they were having suicidal ideation, but they also broke up with their boyfriend or their girlfriend. And, you know, there's a lot of family stress at home. And how do we sort out whether the medication was causal in terms of the suicidality versus some of the other stress? And that's a tough thing to sort out. And again, people might benefit from phone consultation or face-to-face consultation, but feel free to make use of MCPAP consultation resources fairly liberally. We would generally recommend that at the 4-week mark, do a reassessment of the symptoms using a scale, the Mood and Feelings Questionnaire or the PHQ-9. If the score is higher than the cut point and impairment persists, it may be time to call the MCPAP child psychiatrist for next steps. If we're moving in the right direction and the score is decreasing, impairment's improving, then you could probably continue that medication for 6 to 12 months on your own without necessarily getting MCPAP input. And then once kids are feeling better, you know, we want to make sure they stay better, so that monitoring them, you know, twice a month for the second 4 weeks and then monthly afterwards for, you know, continued remission of symptoms or any worsening problems, treatment emergent side effects, or anything like that that can come up in the follow-up period is important. And if anything comes up that you weren't expecting, again, make sure you give MCPAP a call to discuss it. If kids are really doing well for 6 to 12 months of successful treatment, reassess their symptom severity and, you know, potentially consider coming off the medication for families. So when I talk to families, and then one of the questions that's on their mind, either explicitly they ask me, or I know it's on their mind, you know, if we start medicine, does that mean that they're going to be on it for the rest of their lives? And I would say no. In the vast majority of cases, people aren't going to stay on this medicine the rest of their lives. They're going to, you know, hopefully we have a good, successful outcome and kids are going to be feeling better. And once they're feeling better in a sustained fashion, we would try to get them off the medicine. Maybe they don't need the medicine any longer. There are a very few number of people, adults, kids, that every time you try to come off the medication, the symptoms relapse. And then those families or kids might choose to stay on for longer term treatment. But that's not how I think of most situations going into them. I think, you know, acute treatment, hopefully they're feeling better, you know, make sure they do well in the follow-up period. And if they're doing well for an extended period of time, 6 to 12 months, you know, be open to or initiate discussions about how long kids are going to remain on medication. If we can get kids off and they don't need the medication, I think most of us would be happy to help families with that. Again, just a reminder that the algorithms are not the best starting point for the severely ill, treatment-resistant, highly complicated presentations of mental illness in the primary care. And we just hope you guys make use of MCPAP for phone consultation, face-to-face consultation, discussion, to help support you in your work with kids and families. So that's all I have in terms of content. I'm really interested to hear from folks about, you know, comments or questions, and we have, I think, till 1:15, so
Yeah,
we've got about 12 minutes.
Thank you, Bruce. There is a question that was asked by Leah Spitzer. And unfortunately, she's not on the line. I sort of wanted to defer this to kind of a later stage of the presentation, but her question was really about you know, the management of patients with suicidal ideation, and I think this is a really important area for us to kind of talk about today, just because it's one of the, you know, sort of really fraught, you know, sort of aspects of managing depression, you know, in any setting, and especially in the primary care setting. But she was pretty much sort of asking just about you know, sort of what your thoughts about it are about working with patients who have suicidal ideation without a plan or an intent. And so I wonder if you could speak to that, and also more broadly about sort of how you assess, you know, suicidal ideation and how you think about it.
Sure. So I think it's a great question, and you know, there have been studies asking kids, like when kids who have clinically significant depression, whether suicidality is a component of it. And the majority of kids with depressive episodes actually have some level of suicidal ideation. And suicidal ideation or suicidal thinking, suicidality can range from what we call passive suicidal ideation, which means is more like, oh, I wish I were dead. My life is terrible. There's no reason for me to get up in the morning. If I died tomorrow, nobody would miss me. To, kids who got, plans about how they're going to hurt themselves. They also have intent, I'm fully committed to doing this. It's just a matter of time. So there's a whole gradation to stuff, but we can't work with depressed kids without recognizing the concerns about suicidal thinking and suicidal behavior. So I do think as part of the evaluation, it's very important to ask questions, and kids who are depressed, it's not like there's always this concern, oh, if I ask a kid about suicidality, I'm going to put that thought into their head. And it generally doesn't happen. It's not evidence supported. What is more of a concern is for kids who are really suffering and having suicidal ideation, they keep it to themselves because they don't want to trouble people. They don't want, a lot of fuss. They don't want people coming and saying, oh, you're gonna have to go to a psychiatric hospital. So we do want kids to, to share with us what they're thinking. And sometimes it's scary. I think when you're dealing with passive suicidal ideation or suicidal ideation, which doesn't incorporate a plan or has, no intent. Like some kids say, yeah, I think about suicide, but I would never do it because I have 16 different things that I'm living for. But sometimes I'll be honest with you, I have thoughts about suicide. I think we can work with those kids on an outpatient level. And I think that's not uncommon, and always let families know if things get worse, you're not alone. We have 24-hour-a-day crisis services available, so that if suicidal ideation or suicidal thinking moves from sort of passive to active, or from active without a plan to active with a plan, you can always get help. And don't be surprised and don't think it's a failure if you don't. But we have to do a good assessment about it. And sometimes, even at my level, I've been doing this for 30 years, I need help because I'm not quite sure what's going on. And I will refer the kids and families for a crisis evaluation as almost a second opinion, like I think they're okay, but I'd really like somebody else to see this kid. MCPAP is not an 24-hour-a-day or urgent program, but if you're working with a kid in your practice and you want to run a case by a child psychiatrist, that'd be another great reason for talking to a child psychiatrist and getting a phone consultation. If the kid is safe, maybe eventually getting a face-to-face consultation. It's extremely important. And I do think, one of the things when we talk about sort of practice preparation, if you're going to screen for depression, if you're going to follow the MCPAP algorithm, be prepared that sometimes you're going to find kids who are, seriously ill and imminently in danger. And you got to be prepared in advance. You got to know your local crisis numbers and who you're going to contact and how you're going to get help for the kid. It's a very, very important issue, but it's very manageable. Primary care folks can manage it, and MCPAP can help you manage some of the cases as well.
Thank you, Bruce. There's a few more questions coming to the chat. I was just going to add that, or just reinforce the point that you made that when you have a patient with suicidal ideation, the first job is to make sure that you know about it, because and sometimes you won't know about it unless you ask. But it's really important that other people know about it too, because, for these patients, you're going to have a treatment team. The parents really should know about it. The patient's therapists should know that this is an issue. And I think people need to kind of form this kind of supportive sort of network around the patient so that people are kind of aware of this, being an issue, so that it can be inquired about, periodically and monitored, and so that appropriate steps can be taken to address it, if it becomes more acute. But a lot of patients, a lot more patients than we realize, I think oftentimes with depression, have suicidal thoughts that are kind of floating around, in the back of their minds or in the front of their minds. And so it's a really, really important part of the assessment. You know that there's a question on the PHQ-9 about it. And just clinically, it's just an important thing to be talking about with patients and with other people who are involved in the care of the patient, whether it's clinical or natural supports as well. Of course, you know, ideally with the patient's permission, sometimes, you know, you have to kind of do what you need to do. And of course, you know, we can waive confidentiality if we feel like there's an imminent, you know, risk to a patient. So there's a few other questions that I want to see if we can get to. I think it's going to be quick, sort of like a lightning round, you know, if you will, of some questions, because we only have like a few more minutes left. But one is the ideas about patients with depression and anxiety during COVID, and if you want to speak to, you know, the relationship of COVID to this. And then there's a couple other questions I think I'll just mention now, and I'll remind you because it's hard to kind of juggle them in your mind. But there's a question about, is there a minimum age at which PCP should consider treating with medication for depression or anxiety? And then the last question that's out there is, does self-cutting behavior influence your referral prescribing thoughts? But why don't you start with the COVID one?
Well, as everybody is aware, COVID is an enormous stress on our society, on everything. And, you know, there are models of depression which are called sort of stress diathesis model, that diathesis, again, being at risk for it. And then, you know, having risk factors, either genetic risk factors or biological risk factors or psychological risk factors. And then stress piled on top of diathesis can lead to depression. So, you know, and the other thing which I think it becomes hard to tell sometimes is that, you know, we have in psychiatry called an adjustment disorder. Adjustment disorder means that something has changed about your life, it's caused stress and you're having a negative reaction to it, but it isn't necessarily the same as like a more long-lasting kind of sustained mental illness like clinical depression can be. So you can see both, and we've seen both. We've seen clearly kids who are having really serious adjustment reactions with anxiety, depression, changes in behavior. And we've also seen kids who are clearly in the throes of a major depression, most likely brought on by the severe stress of COVID. So, you know, so sometimes, again, we wouldn't generally think about treating adjustment disorders with medication for the most part, but sometimes adjustment disorders can be prolonged and can lead into a depressive illness. So COVID is a major stress. Kids are reacting to them kids are reacting to COVID all over the place. Sorting out adjustment disorder, clinical depression, try to do your best as a primary care provider. And if you need any help with that, again, that would be a good reason to contact MCPAP. Let's see, the second one was?
The minimum age.
Minimum age, yeah. So I would say not an absolute minimum age. I'd say it's probably pretty rare that we're going to treat kids under the age of 7 for depression. I mean, that probably is a lot more specialized kind of treatment. The FDA guidelines are 8 and above for fluoxetine. So I would say no absolute minimum age, but if you're considering treating somebody under the age of 8 with an antidepressant, that may be something you might want to run past a MCPAP consultant just to get some support on that and some input. The third was about the cutting. So I treat a fair number of kids in specialty care who are depressed and use self-injury as a way of coping, you know, and there is a distinction between kids using cutting as a way of coping, either coping with interpersonal stress or intrapsychic difficulties, and self-injury that's not involving suicidal thoughts at all. It's about, you know, again, it's probably a maladaptive coping strategy. Everybody who cuts is not suicidal. A fair number of kids who cut do have some issues with suicidality. They're not exactly the same, but if I have a kid who is cutting and severely depressed, I will follow generally a depression treatment algorithm in my own mind, in my own specialty care. Ideally, those kids would need to be followed a little bit more closely in terms of safety issues. Ideally, they'd have a therapist involved to try to help them develop better coping mechanisms as opposed to utilizing cutting as a primary strategy. It's not uncommon, but it's not a rule out. It's not like because somebody is cutting, you shouldn't use antidepressants. I wouldn't think of it like that. I would think if it's depression with cutting, I would treat them for depression using medications, using evidence-supported psychotherapy, follow them closely and keep an eye on the cutting, and encourage them to develop maybe different coping skills, because cutting only gets you so far as a coping skill.
Thank you so much, Bruce. So we are at the end of our time. And so I just want to thank everybody for their presence and attendance and all the great questions. And thank Bruce for the wonderful presentation. Once again, the encore presentation. And again, finally, just please use the questionnaire and give us some feedback, because we're always looking for that. So thanks, everybody, and have a great rest of your day. We'll see you next month.
Bye-bye.